7, 6, 5, 4, 3, 2, 1.
Howdy, CROC Nation. Dr. Tom Iannelli here with you, along with Angel Santana, Have Faith, Let It Begin, and Professor Len Berry, part 2 of a 3-part module in regard to healthcare healing mission for a sustainable future. Professor Berry, thank you very much for joining us again, and we're going to thank you. We're going to just keep thanking you and thanking you and thanking you.
Tom, it's my pleasure to be in your podcast anytime you want me back. It's just so much enjoyment and stimulation, and just so rewarding to spend time with you and Angel. You two do such a great job on the podcast. It's a wonderful service, and so my pleasure. Thank you.
So behind peeling the curtain back, we have a little bit of an advantage over you survivor thrivers in the sense that we have good continuity because we're going back to back to back. But you guys are listening to this in real time, so this will be a 3-week mini course in excellence for you guys. So today we're going to talk about with Len 3 critical subgroups or subpopulations that really challenge the healthcare system. That's the poor, the elderly, and the healthcare worker themselves. Len, can you segue us into the poor? There's this very profound story about Chloe, about the fact that this was a young person who had cancer, whose father was in jail. Her mother, desperate for income, couldn't even pay rent, was working 3 jobs. Chloe gets sent to live with relatives and misses many of her medical visits. And unfortunately, Chloe never makes it to the 1st grade. I think that's such a profound and moving introduction to healing the poor.
The tragedy of our times certainly includes stories like Chloe, Tom, because there are many Chloes. There are, in this nation of ours, there's extensive poverty, and we know empirically, we know with a great deal of evidence that the poor get less health care. The poor face more obstacles to healthy living than any other segment of society. That shouldn't be. It truly is a tragedy of the commons, but it is our reality. And we start the section in the article about Chloe because it is such a heart-rending tragedy, but it's just one story, unfortunately, of many stories like it, where a child, because of being poor, doesn't have the same access, doesn't have the same opportunity for a healthy life, for a full life, for a good life, as children that grow up in greater circumstances when it comes to income. And this is due to our misalignment that we talked about last week, Tom, of resources and incentives and policy. And pediatricians, as it turns out, are the lowest paid of all the medical groups in our country. How can that be?
Profoundly underpaid. I agree.
I mean, just think about that. And I hope your listeners will think about that for a minute. Why is our country so good at misaligning resources? We pay pediatricians the less. We should pay them the most. They're taking care of the kids. They're taking care of the future.
Yes.
why do we pay school teachers so little? Um, you know?
Yeah, no doubt. And then what I found to be really interesting, and we kind of touched on it last week, I look at this as a fragmentation issue. I look at this where we're not seeing the whole picture. So when you see a kid who's in trouble with healthcare because of poverty, then what happens is you have this vicious cycle where then they have developmental delays, cognitive impairments, poor educational outcomes, long-lasting health issues, and it's just a spiral that adds to the dysfunction of the system. And what I found to be interesting was, and I want you to comment on this, there's a sort of a new role or a new field coming out, which I think probably Dr. Hole is part of. It's called anti-poverty medicine. Can you comment on that?
Yes, Dr. Hall is one of the leaders of anti-poverty medicine in the country, and I'm just so proud of him for the work he does. He inspires me. I have him speak to my students each year, and he inspires my students. Anti-poverty medicine is medicine that is specifically focused on realigning resources, realigning them to serve the poor. So, for example, anti-poverty medicine includes mobile medical vans, mobile medical vans, where a physician, a pediatrician, and a nurse get in their own van equipped with medical supplies and go into low-income neighborhoods in their community and where kids live, and take care of sick kids and make sure they're, to the best of their ability, they get the care that they need. They go into the communities to try to find the Chloes that are there in the low-income communities. Dr. Michael Hole, that I mentioned before, for many years, he took one day a week out of his practice, out of his academic career, one day every week, and got in his mobile van and went into low-income communities in Austin, Texas, where he lives, and to serve low-income children. So that's an example of anti-poverty medicine. Here's another example of medicine partnering with other institutions in society, such as financial institutions. And in the article, we write about a program that was started at Boston Medical Center. It's called Street Cred. Street Cred. And what Street Cred does is it has a financial staff person, often a volunteer, sometimes working for a medical clinic, sometimes a volunteer to the medical clinic, who will go into the waiting room of a medical facility that serves primarily low-income people, and will help low-income people while they're waiting in the medical waiting room, help them file their taxes, help them claim tax refunds that the family didn't even know they were entitled to, and help open up what's called 529 children's savings accounts. And they'll do it while the patient and the family are waiting in the waiting room. And what Street Cred has done, this is such a great example of the collaboration between medicine and financial institutions. What Street Cred has done is, in about 6-7 years since it's been operating, it has returned over $14 million to over 6,000 families free of charge.
Amazing.
Families in poverty. It's
Amazing.
an amazing program.
Yeah.
This is one of the programs that Dr. Hole helped start, among others. He's a medical entrepreneur serving low-income families, particularly kids.
Absolutely. And again, what a collaborator, and one day we'll have to connect with him. Len, can you comment briefly, because there's so many, I mean, it's beyond the scope of this podcast to get into every one of these examples. Like the drones and all that kind of stuff, but bringing medical supplies. Let's talk a little bit about policy opportunities to reduce poverty.
Yes, yes. We have some really good programs that are endangered, where in some cases they're federal programs, but they're not adopted by certain states that are just resistant to federal programs of various types. Programs like the Supplemental Nutrition Assistance Program, better known as SNAP, Supplemental Security Income, SSI, to ensure access to nutritious foods and financial support for millions of people that are low income. These are wonderful programs. These are programs that serve well-being. That these are healthcare programs, because if you don't have enough to eat, if you don't have the right foods to eat, if you don't have proper nutrition, that's going to raise the probability of illness, and then these patients come into the healthcare system, and so we're paying for it backwards instead of paying for it forwards, Tom.
Yeah, absolutely. It's absolutely backwards. And it's a nice segue now into we'll get into the healing of the elderly. One of one of the areas that you hold dear to your heart.
Yes, those of your listeners that remember from last week's podcast, if they listened, we talked about one of our greatest failures in American healthcare is failing the poor, but one of our other greatest failures, Tom, is failing the elderly, particularly the elderly with multi-morbidity, multiple chronic diseases, and the elderly with life-limiting diseases. We're failing them miserably in American healthcare today, and I have a great interest in seeing what I can do to reframe the opportunities. And this paper is one of the papers that I wrote on this topic.
Yeah. Oh, absolutely. And it's kind of it's so dear to my heart as well. I have two personal stories that I'm going to interject with your comments. Number one, talking about, well, we've already talked about the slippery slope of overtreatment. And when we talked about physicians having the opportunity and the obligation to be able to transparently, compassionately, but absolutely realistically discuss these very sick patients with multiple comorbidities and some of the futilities of care, and when to segue into a less invasive situation. But I'll start with the failure of the nursing home. I got a text from my cousin, who's a very young man. He's not even 64 years old, and he has a bunch of medical problems, just like many of the people discussed in this article. Suffers from poverty and all the associated ills of that. And he's in a nursing home with a bunch of things going on. And he basically wrote to me today, frankly, I'm giving up on everything around here, and I'm at a point where I just don't care. It looks to me that this is the end of the road. And it's really not, but that's the way he feels, because he is in this nursing home. You talk about isolation, you talk about loneliness, you talk about just the plagues of the nursing home. Can you just comment on that?
Yes, the nursing homes is a failing industry. In the article, we mentioned the three plagues confronting many nursing home boarders, patients. And those three plagues are boredom, loneliness, and helplessness. And the story you just told, Tom, about your relative illustrates the three plagues: boredom, loneliness, and particularly helplessness. But that doesn't have to be. We can do so much better with some imagination and some real leadership and some appropriate funding and reimbursement of nursing homes. And we have an example in there of a nursing home leader, that a physician, his name is Bill Thomas, and he was written about in Atul Gawande's wonderful book, Being Mortal, where he came into a nursing home leadership position and he saw the three plagues and he decided, you know what, we can fix this. And so what did he do? He planted a garden outside the nursing home.
Beautiful. Yep.
Yes, and so that those residents that wanted to could help tend to the garden and be in nature, be outside on a nice day. He brought green plants into the living quarters. He added a vegetable garden that the residents could tend to. And controversially, but very successfully, he brought animals into the nursing home, dogs and cats and parakeets. And residents, if they wanted to, could adopt a particular dog and have the dog stay in their room and feed the dog, take care of the dog. Well, he got a lot of pushback when he did this. Oh, you can't do that. And the reason he got pushback, Tom, this is important, is too many leaders of nursing homes see their sole goal as protecting the patient's or the resident's safety. But you can't have that as a sole goal, because then you take everything else that's meaningful in life away. If you're so concerned about their safety that you won't let them outside, you won't let them walk around, you won't let them tend the garden, you won't let them feed the dog. If you're so concerned about their safety, you're taking away everything that's meaningful to them, and it leads to the three plagues. And so Bill Thomas, such a wonderful example of the possibilities of reinventing the concept of a nursing home. It doesn't have to be bleak institutional living. And we need better staff in nursing homes. Right now, it's very hard to attract excellent staff to nursing homes because we underpay and because the work in a traditional nursing home that isn't reinvented in the way I just discussed, that work is bleak. And so it's a vicious cycle. And yeah, we need.
I have to say that one of the things that probably the only thing that I would have added to your article is that, and this is a perfect example, is that I think we have reached the point in medicine where we are so freaked out about the medical legal implications of everything and the fact that it's such a litigious society that I think that people are so afraid that if someone in the nursing home ever fell while they were petting a dog that was giving them joy, or if they were in the garden and something happened to them, that they would get in trouble or they would lose their job, or the family would sue them, and I think that there is a lot to be said for reform, in that medical legal, avenue.
Absolutely agree. And it's an excellent point, Tom, is we are so litigious, and physicians are properly concerned about malpractice, because just one malpractice lawsuit can actually change a physician's life. And I've interviewed physicians who suffered from malpractice lawsuits and talked to them about how life-changing that can be, how stressful and anxiety-producing that can be. And so, yes, it's an excellent point, but we have to reform that part of the medical legal part of our healthcare infrastructure in order to take that fear away so that we can, because patient safety clearly is important. I don't mean to de-emphasize or
No, you're not at all. But you also you want people to live again when we talk about, people, being able to live their best life. There is risk always. And believe me, that did not come across as you not being conscious of their safety. But what you would be proud of, Len, is, and then this is now a good story. I told you a bad story, but I'll tell you a really good story. So my mother was an innovator. So in the day, we all thought my mother was a few sheets to the wind to the left, where we thought she might have lost it. But her position was always, and this is 20 years before healthcare at home came along and all of this power of pace and, the different programs. My mother said to me very, very clearly, I am not going to the hospital. I am going to stay home. This is where I want to be. If I can't get cared for here, then I would rather die. And let me tell you something, for 20 years, I was always waiting for that call. I fell and I broke my hip, or my mother was found dead on her floor and the whole thing. But God bless her for 20 years. And this is a great story because it's the perfect story for your article as we're finishing out the elderly. She basically, the government loved her because she didn't go to the emergency room. She didn't have 3-month admission. She didn't cost them anything. And in exchange, they would send a doctor every once in a while to examine her. They would send somebody to draw blood to check her INH because she was on Coumadin. They would send a podiatrist to cut her nails. When her heater needed to be replaced, they put a new heater in. If her air conditioner needed a new air conditioner, they took care of that. They would put in light bulbs. They would fix her house. And at the end of the day, my mother probably saved the government about $10 million. In exchange, when she sold her house, or when she passed and the estate, when her house went to estate and the house was sold, I happily gave that money back to the government because the government allowed my mother to be independent. It allowed her to be happy. It allowed her to live the life she wanted to live. And I think that's one of the stories that is a good story and an absolute lesson, for how we could change the model. Len, your thoughts?
Well, my thoughts are that first of all, that's a beautiful story. Second of all, we need more stories like that because one of the ways, Tom, we are failing the elderly is we're overtreating. We're doing more in the hospital that we could be doing at home. We are often focused on what's the matter with you rather than what matters to you. And what matters to your mom was that when the time came, she would be at home and not in a hospital. She would not be someone that would be hooked up to one device or another and going through one treatment after another that had little chance of doing anything but just making her sicker, making her more lonely, making her more uncomfortable. But we have a program, we write about it in this paper, Tom, called, we have a program in America called PACE. And it's such a marvelous program. I studied it when I was studying at the Henry Ford Health System in Detroit for 3.5 months in 2022, which itself, Henry Ford Health is such a wonderful organization. Perhaps for another podcast, we can talk about my study there.
Oh, I would love that. And I think that you were there with Raina, right? With Dr. Oddish.
I was there with Dr. Oddish, one of my closest friends, Rena Oddish. But I studied PACE because Henry Ford has one of the most successful PACE programs in the entire country, perhaps the most successful. What PACE stands for is it stands for Program for All-Inclusive Care for the Elderly. And it's a program designed to keep lower income people who are elderly and who have chronic illnesses. It's a program designed to keep people like that in their homes rather than forcing them into institutional living like a nursing home. And so what PACE involves, it involves primarily serving what's called dual eligible patients. These are patients that are eligible for both Medicaid and Medicare. And if they're willing to take their Medicaid and Medicare reimbursements and use them for PACE, then all the expenses for PACE are free to them. And what PACE does is they'll do what you described in your story about your mom. They'll go in the home and make the home, they'll upkeep the home, they'll make the home as safe as possible. If the porch needs fixing, so you can climb up the porch, climb down the porch without falling, they'll fix the porch. The plumbing needs fixing, they'll fix the plumbing. If you need somebody to help you when you take a shower, they'll have a staff member who's in your home helping you take a shower. So that's one part of PACE. Another part is daycare, facility daycare, where PACE will pick you up from your home, bring you to the PACE facility for the day. You'll have a couple of meals there, breakfast and lunch with friends, other PACE members, other PACE participants. And so you develop a social life with other PACE members. And there's various activities, and there's a gym, and there's rehab, and there's a medical clinic, and there's all of these services during the day for PACE members. And then they provide medical care in your home when you need medical care in your home. All of this is free if you're a Medicaid, Medicare patient, and Medicaid, Medicare pay for that. Tom, there's 60,000 members of PACE in America today, 60,000. That's such a small number. There's more than 12 million dual eligible patients in America today.
It's unbelievable, Len.
What a missed opportunity
know,
we have
know.
there.
Yeah.
Yeah. So that's just one of many things that we can do and to help the elderly. We're failing the elderly. It's one of our biggest opportunities in reinventing healthcare, making it more sustainable, and putting mission back into the center of healthcare.
Len, was so well said, and I'm glad we actually took our time and really dissected that particular segment. That was very important and very wonderful. But in order to heal our patients, you would agree we would need to heal the healers. So we'll end this part 2 with just a few words about burnout, moral distress, and how we could help people like me continue to take care of patients.
Well, we can start with better leadership of many of our healthcare systems and institutions. Healthcare has become too focused on the bottom line, too focused on profit rather than people, too focused on the financials of healthcare, and not enough of a focus or emphasis on the true healing that we've talked about in yet last week's podcast and today's podcast and next week's podcast. The true mission of healthcare is healing. And physicians who enter healthcare, Tom, such as yourself, who enter healthcare to truly serve, who enter healthcare for the purpose of creating more wellness, more well-being, more happiness in the lives of the patients they serve and the families of the patients. Many of them today exhibit one or more clinical signs of burnout. Burnout, where the passion that you once had for healthcare gets burned out. And it leads to a variety of negative consequences, including more medical errors, including physicians leaving their practices early, retiring early, leaving healthcare entirely. The pandemic didn't help. It just made burnout worse, but we had burnout before the pandemic, and we have even more burnout now after the main part of the pandemic. And a big factor is there's a multiple causes of clinician burnout. It's not just doctors who are burning out, it's nurses and other caregivers that are burning out, including family caregivers who are taking care of their loved ones, who are not paid for their care. They're burning out too. And there's a lot of evidence about that. So that's healing the healers. It's about taking better care of the people who are taking care of the patients. Because if we don't do that, we can't take better care of the patients.
Well said, Len.
Yeah.
Angel Santana, we talked about poverty. We talked about care of the elderly. We talked about care of the healers. Your thoughts?
You know, it's interesting because listening in, I feel like this is part of my wheelhouse as far as our podcast, Have Faith, Let It Begin, because we do talk about leadership a lot and the elderly. So I've got two thoughts regarding leadership as we closed out on that. You know, leadership, in my opinion, in what we've just took in tonight, can be best quoted as saying, if your actions create a legacy that inspires others to dream more, or learn more, or do more, and become more, then you are an excellent leader. And I think that's what's lacking. We just need more leadership. And to segue into the whole portion about the elderly, you know, Nelson Mandela put it best when he said, we must work together to build a better world for our children. And that's starting with caring for the elders. Because you remember, at the end of the day, to provide care for the people who once cared for us is the greatest honor that you can do.
Well said. You are a wise man, Angel. Well said.
He doesn't sit in that chair for no reason, Len. He's my, he grounds me. CROC Nation Part 2 of 3 with Professor Len Berry, Reclaiming Healthcare's Healing Mission for a Sustainable Future. Angel will make sure Rod puts the link to the article on the website so people can read this article. It's very readable and it's very important for healthcare. Next week, we'll close out with Professor Len Berry. Len, thanks for joining us. We will see you on the other side for Part 3.
Don't forget, everyone, the CROC podcast is available every single Sunday at 9 o'clock Eastern Standard Time. You've just completed episode number 2 on this 3-part series. If you failed to listen to the first episode, go back to April 14th. April 21st is episode 2, and we will close out the month of April with Part 3. We'll see you next week.